هذا بالماضي. خلق مبارك مع بعض. مبارك مع بعض 29.
Dr. Sajadullah will be entering soon. He is now trying to connect online. So we'll be waiting for a few minutes until he's in. Dr. Sajadullah, how are you?
Can you hear me?
Yes, we can hear you, but the internet maybe is a little bit slow.
Yes, there is some technical issue, and that's why. Sorry for the delay.
No problem.
Let me share my.
Okay, you can start screen sharing. And now I will do welcoming for the audience. Then Professor Khalid Belmadi will introduce you, and then you can start. Okay.
Okay, sure.
So welcome everyone to the second webinar of the comprehensive neuroanatomy educational program that organized by the many neurosurgical society in collaboration with the World Federation of Neurosurgery and Neurosurgery Forum and Neurosurgery Coach, along with the Pakistani Society of Neurosurgeons and Neurosurgical TV. Today we will start our seventh session of the 13th of Module 2. And the moderator today will be Professor Khalid Belmadi, Professor of Neurosurgery at Hadramaut University, and one of the main figures in the Yemeni Neurosurgical Society. Professor Khalid, please, you can start. You can please unmute, Doctor. Professor Khalid, you are muted.
Okay, Dr.
Yes.
Ahmed.
Yes, now it's good.
Good evening for all. It is a pleasure to be here today with you, and I appreciate your time and presence here. Thanks for my colleague in Yemen Neurosurgical Society and Dr. Ahmed Al-Garadi, also with our speaker today, Dr. Sajad and Dr. Shah. The topic of discussion today I listen or I see that according to program pituitary gland, anatomy of pituitary gland, and hippocampal formation. This is good topic, and welcome with for speaker today. For thanks for all member of Yemen Neurosurgical Society and my colleague in other countries.
Thank you, Professor. So now we can start with the Professor Dr. Sajadullah Dawar, Assistant Professor of Neurosurgery at Khyber Teaching Hospital in Khyber Medical College, Peshawar. He will talk today about anatomy of the pituitary gland.
Thank you. Welcome, start.
Okay. Can you see the screen?
Yes, we can see it.
Okay. Thank you, Professor Khaled and Adul Al-Jad and the Yemen Society of Neurosurgeons for inviting me. It's a quite different thing when you teach the undergraduate because I'm also faculty for the Khyber Medical College, which is the most prestigious medical college in this part of the some 60-year-old medical college. So there is a lot of difference between teaching the postgrad and undergraduate. So the topic, I tried to make it as simple as possible and to avoid as many details as deemed not necessary for the undergraduate student. So starting from the scenario, a 45-year-old male present with 6-month history of progressive vision loss, particularly difficulty seeing objects on the sides, and frequent headaches localized behind the eyes. He also reports decreased libido and fatigue over the past year. On examination, there is a biotemporal hemanopsia is confirmed, but the rest of his neurological and endocrine exams are unremarkable. So with this scenario, when most of the patient neurosurgeons are sitting in the OPDs, outpatient department, we get this sort of patient, and the first thing that comes to our mind is that there is some problem with pituitary or cell area because the biotemporal hemanopsia is very specific for this sort of pathologies. So coming to the anatomy of the pituitary gland, this is me, and the learning objectives for the today is by the end of this lecture, the participant will be able to understand the embryology of pituitary gland, the anatomical location related structures, vasculature, hormones of the interior and posterior pituitary glands, clinical importance of pathology, some surgical approaches, a bit of, and some historical background of the pituitary surgery. So pituitary gland is a small and oval-shaped gland that is attached to the undersurface of the brain by the infundibulum. The gland is sometimes called as the master gland, as it involved in many processes that is vital for life. So you don't go for the size, but for the importance, because without pituitary, life is unimaginable. I think the best part to learn anatomy is if you know the embryological origin and that how it originated, how it started making, then it become very easy to understand the function as well as the anatomy of the pituitary gland. So the embryological origin is that there is an oral ectoderm. If you can you see my pointer? You can see the mouse or not?
Yes, we
Doctor?
can see it, Professor.
Okay. So if you just look at this ectoderm, this is oral ectoderm, which is going into the other ectoderm, that is the brain will develop from this ectoderm. So it goes inside it and pushes over here. So this the brain part of the ectoderm is moving downward, and the oral ectoderm going inside this brain room. So with this process, a pouch is made that is called Rothke's pouch. It start at 4 week of gestation, 4th week of gestation, and completed or 8 week, it become 6 to 8 week, it become discontinued, and just a remnant is there. Otherwise, you can see it become like this. Then it develops into the oral ectoderm and the other the brain ectoderm. They combine and make the pituitary gland, which is connected with the other part of the brain through the stalk. So this is the whole. If you can see that pars tuber wraps around the infundibulous stalk, and then there is a cleft, then which is a pars intermedius part, then pars nervosa, infundibular part, and a pars tuberosa. So these are the various part of the pituitary gland that will develop from the structures later on. Now, coming to the anatomical location and relations of the it has with a small depression in the sphenoid bone known as the sella turcica, which is basically it's called sella turcica because the Turkish saddle it is of this shape, and it resembles this Turkish saddle. That's why it's called sella turcica. Between the optic chiasm and memory body is posteriorly and optic chiasm anteriorly. The superior surface of the gland is covered by reflection of the dura mater called the diaphragma sella. So this is the now we will discuss in detail all these relations, but just for sake of a quick view, the anterior is optic chiasm, then the posteriorly is the intercavernous sinus is dorsum sella, basilar artery, and the pons. Superiorly is diaphragma sella, as we have seen, and optic inferiorly is sphenoid sinus. You can see over here, and then left side is a cavernous sinus. This is the actual picture from this is the sphenoid sinus, this is the pituitary, this is the brainstem, this is medulla pons and midbrain, and these are the superior turbinate, middle brain, inferior turbinate, which is important in the surgical point of view when we do transsphenoidal surgery. Now, if you look at the base of the skull, when the brain is removed, you will see that this is a lesser wing of sphenoid, and this is a greater wing of sphenoid bone, greater wing of sphenoid bone. Then there's the optic groove, and then there is a tuberculum sella. In between the tuberculum sella and posteriorly the dorsum sellae, this is the depression that is called sella turcica, where the pituitary gland is present, and this is the anterior gliadal process, and just beside this, we have the most important structure of the arteries, and then the sinuses, cavernous sinus is there. So if you look into cadaver dissection, now this is sella, this is tuberculum sella, and this is the dorsum sellae over here, and the pituitary is light over here. You will appreciate it over here. If you add structure into the picture, as so you can see that the pituitary gland is lying over here. This is the anterior pituitary, and this is the dorsum sellae. The posterior part of the pituitary gland is hide behind these dorsum sellae, so it's not that visible. You have to you have to remove part of it, then it will become visible, and it is connected to the through the stalk with the hypothalamus. Over here, this is the internal carotid artery that it's called, and this is a paracellular area where we have just removed the sinus, cavernous sinus. If you add further, this is from the lateral side. This is the pituitary gland. We are seeing it from the lateral view, side view, and it's there in the sella turcica. Now, adding some further structures to the picture anatomically. If you look over here, this is the posterior lobe of the, and this is the anterior lobe, and this is connected to the third ventricle and hypothalamus to the pituitary stalk. This is the pituitary stalk, which is communicated with the third ventricle, because the hypothalamus makes the inferior floor and the lateral wall of the third ventricle. So it is connecting the with the hypothalamus. The stalk, pituitary stalk, is connected with the hypothalamus. So over here you can appreciate the chiasm, and that it is just above the pituitary gland, and that's why whenever there is there is a tumor of this region, you will see that it causes compression on the compression of the chiasm, and that's why the because in the chiasm the fibers cross. The crossing fibers of this optic nerve, they cross, and with at the cross where they're crossing the chiasm, they are compressed, and that's why the biotemporal hemanopsia we get in the patient. So it compresses the chiasm over here, and that's why we see the patient the picture with the biotemporal hemanopsia. If we add some other structure, then you can see that this is the chiasm, and then we have added the hypothalamus. That is, this is the mammary body with that, and this is the pituitary stalk, and this is the pituitary gland, and the some part of the. So it is connected with the hypothalamus, and then further with the mammary body, and with the other part of the brain through the pituitary stalk and the other structures. So it is very much connected with the hypothalamus. So that it's dependent on hypothalamus for various functions as well. This is another clear picture of hypothalamus, that we can see the pituitary and the hypothalamus structure, how it is interconnected, and how it is in coherence with the pituitary gland, because the hormones, some hormones are produced in the brain, and then it's just transported with the through the hypophyseal system that we will later on read. It is bringing down to that level. This is a little bit of the anterior hypothalamus and posterior hypothalamus. The anterior hypothalamus controls the posterior pituitary hormones. If you see that there are various nucleus in the anterior hypothalamus, there's paraventricular nucleus that function is for the oxytocin release, and supraoptic various hormones. So basically the point to learn for the undergraduate is that the anterior hypothalamus main function is to give hormones and control the posterior pituitary. So while the posterior hypothalamus is morely with other functions like satiety and neuroendocrine control, thirst and hunger, and blood pressure, etc., etc. This is controlled by the different nuclei of the posterior hypothalamus. Now, this was a little bit of anatomical, the cadaveric, but just to revise that the pituitary gland is of two parts, that is anterior and the posterior. The anterior are adenohypophyses. It is composed of glandular epithelium, and there's a number of hormones. It can be further divided. The anterior pituitary can be further divided into pars anterior. This is the largest part, and this pars of hormone secretion, and pars intermedia, a thin epithelial layer that separates the pars anterior from the posterior lobe. You can see over here, and then pars tubularis, an upward extension of this pars tubularis of this that can just surround the anterolateral aspect of the infundibulum. This is infundibulum, and this is the pars tubularis. Now, the anterior pituitary gland is under control of the hypothalamus, so which communicates with the gland via neurotransmitters secreted into the hypophyseal portal vessels system. The vessel ensures that the hormones is concentrated and it's not diluted, and it's reached to the area where it should be, and where it needed to be. While the posterior pituitary gland, the posterior lobe, that is also called as neurohypophysis, consists of the nerve tissue. That's why they say that the posterior pituitary is an extension of the brain. It's not the gland, but the hormones are made somewhere else, and it's just a storage and releasing point. It does not produce the hormone by itself. So it arises from the embryonic forebrain and is in essence extension into the hypothalamus. The posterior lobe secretes two hormones: the ADH, that is responsible for the control of blood osmolarity, antidiuretic hormone basically, and the oxytocin that is involved in pituitary and milk secretion. Both of these are produced in supraoptic and paraventricular nuclei of the hypothalamus that we have seen, and then subsequently stored in the posterior pituitary, ready to release for the later use. Some of the vasculature, the anatomy of the blood supply and blood drainage. The vasculature of the pituitary gland is complex in a sense that it's not just the anterior and posterior hypophyseal arteries, but they have another sort of supply through the hypophyseal complex as well. So the arterial supply that is a superior hypophyseal artery, or here you can see this is a supply the ventral part of the hypothalamus, upper part of the infundibulum, and lower part of the infundibulum tubercle artery. While the inferior hypophyseal artery, the divides into medial and lateral branches, the two branches, and then the joint together to form an arterial ring that is around the posterior lobe of the posterior lobe of the pituitary. The branches of the arterial ring supplies to the posterior lobe as well as anastomose with the branches from the superior hypophyseal artery as well. Then the pars distalis, this is supplied exclusively by portal vessels. That portal vessels that we get from the upper part of the brain arising from the capillary from the superior hypophyseal arteries. The long portal vessels drain the median aminus, drain to the median aminus and upper infundibular, while the short portal vessels drain into the lower infundibular. The portal vessel carries hormone releasing factor from hypothalamus to anterior lobe, where they controls the secretory cycle of different glandular cells. Then we come to the venous drainage. The pituitary venous gland drainage occurs through the anterior and posterior hypophyseal veins, which empty into the cavernous sinus. From the cavernous sinus, then the superior inferior petrosal sinus, and ultimately into the jugular vein. The hormones of the anterior pituitary are anterior corticotropic, anterior lobe is ACTH, the FSH, the follicular stimulating hormone, the growth hormone, luteinizing hormone, thyroid stimulating hormone, and protein, which in turn affect almost every part of the body. Oxytocin on the breast and uterus in females, and ADH on the kidneys, the growth hormones in the bone, muscles, and every part of the TSH for thyroid gland, where thyroxine is regulated. The prolactin is also for the breast, and ACTH for the adrenal glands, FSH on the ovary, and LH from the testes. So these are the various functions that the pituitary gland runs from. The hormone of the pituitary, we already described that it's ADH, antidiuretic hormone, also called as vasopressin hormone, and then we have the oxytocin hormone. Some clinical pathologies that we see, the most common is that of the pituitary adenoma. Then it can be divided in two parts, whether if they are non-functional or non-secreting tumors or hormone-secreting tumor. If it's non-secreting tumor, then the pathology is the pathology it causes by virtue of its size and location. So it compresses upon the optic chiasm, and that's why because of the increasing size, the surrounding dura is pushed and extended, and that's why they feel pain. There's a headaches, and with the compression of the optic chiasm, there is bitemporal hemanopsia. But and it is in more in size. You can see macroadenomas more than 20, 30, or 40 centimeters. So this is because that it's because of the non-functional nature, it increases in size, and it is noted later on. But if it is hormone secreting tumors, then the hormone that it secretes, it will cause effect earlier, and that's why the most of the cases that we come to our clinics is the microadenoma cases, where they're diagnosed earlier because of their secreting hormones. If it's polyclonoma, the patient will come with the say milking from the breast from a non-lactating mothers, and even from males. If it's growth hormone, then you will feel that prognatism, a huge increase in size of hands and feet, and so many other things. You can have also diabetes, early onset diabetes. If ACTH, again they will have the Cushing syndrome. Then if TSH, these are rare, not that common. There's another another tumor that is count from this as because of the origin is called the craniopharyngioma that arise from the remnants of the rod case cleft, and it also compresses the pituitary gland, and most of the time it present with the hyposecretion function, and because of the hyposecretion, then there will be an adult of 18 or 20-year-old which will look like a child because of the hormone suppressions, and it present to us like this, along with headaches, vomiting, and pressure symptoms. Although it's not very much related with the anatomy, but as a neurosurgeon, we are more interested in the surgical approaches. So there is endoscopic skull base, open skull base, and both open craniotomy options are available. Depend upon the size, location, and types of tumor. If it's meningioma, then it's very difficult to do it endoscopically, and if it's adenoma, then it can be done endoscopically very easily. So depend upon the type, the lateral extensions, involvement of the structures, then we can do the surgical procedure, plan the surgical procedure. As in transfemoral surgery, we go through the nose to the sinus and then remove it, while in cranial approach, we do open craniotomies. This is a demonstration for the open case, and the previous one was for endoscopic case. Now, some historical background. Victor Horsley was the first person who attempted the surgical approach for pituitary gland. Who is the first surgeon who operated on pituitary, but unfortunately he was not successful back in 1889. Then the Hermann Schluffer in 1907, he was the first successful surgeon that did surgery for the pituitary gland tumor using transfemoral approach. Schluffer performed the surgery through electral rhinotomy incision in the nose, not with the transfemoral, but he just opened it with the nose, and he did that surgery. He resected the ethmoides, friend sinuses altogether. Later on, in 1910, Oscar Harris developed the intranasal transeptal transfemoral operation. But the father of neurosurgery, Harvey Cushing, is considered to be that he really refined the transfemoral approach and operated on 231 pituitary tumors. In 1960, French surgeon Gerard Goy used an endoscope in a transfemoral surgery. So this is because there was some time limitation, so that's why I tried to finish it before 9 the expected time. So if there is any question, I'm available.
Thank you very much, Professor. Dr. Khalid. You are muted, Doctor. Please unmute. Yes,
Now-
Doctor.
Thank you. For doctor, sometimes in transcranial approach, complication may be done, likely diabetes insipidus and electrolyte disturbance due to retraction in infundibulum or pituitary stalk. Some drugs used in this complication, like vasopressin and hydrocortisone. It is really rule for hydrocortisone in this complication. Some schools necessary to give hydrocortisone. And other question about if pituitary apoplexy happen or done before surgery. It is emergency surgery. Really, some studies now, when there is pituitary tumor in patient and happen pituitary apoplexy, necessary as emergency surgical. Some authorities not agree with this idea. Maybe clear this idea if you have any information about that to help us.
Oh, thank you, sir. Sir, I will share our experience because we almost share the same sort of setups that we are. In the first question is about the use of the steroid and dexamethasone. So most of the time, then that we if the patient, if the tumor is non-secretory, if it's a adenoma, non-secretory adenoma, Then I think there is no role, and we haven't used it any post-op steroid for this patient because adding steroid post-operatively increases the infection rate very much, and the healing process is very much hampered because the first 24 hours is important for the migration of the EGFR and all these things, the growth factors that are necessary for the healing portion. But if it is either other any hormone secreting tumor, then we mostly involve our endocrinology team, and they treat the patient as per the protocol of their blood samples, their various things, and they give the steroid post-operatively as well, because they say that if you just suddenly drops the level of these hormones, then it become sometimes it is an emergency situation where it can collapse anytime. So in secretory tumors we give, and in non-secretory tumor we do not. So coming to the second question, we haven't operated any single patient for apoplexy, and even 2 weeks back, I operated on a patient who got the apoplexy that was almost that patient presented after 7 days. And he said that one day I just felt severe pain, and but then I tried some local GP and some medication, and there was no like what we have read in the book, that it's the emergency situation, you have to operate in the midnight. No, sir, we haven't operated in the midnight, and at least in my practice, I have seen operated on 3 apoplectic cases that were presented late, and all of them were fine. I don't know if anyone died because of this, because we don't have so much data, but so far we haven't operated on any apoplexy patient.
Thank you, Doctor. But apoplexy, I know that, but for medical or medical legal, some cases, one late not enter surgery, some paper now, it is emergency. Why don't enter case this for surgery? For medical legal, this is necessary to clarify for all neurosurgery. It is my opinion, not emergency.
Sir,
But
I
I
agree.
hope to clarify this for all doctors.
Sure. I think the Neurosurgical Society should issue some sort of guidelines that it's not an emergency if it's not operated at midnight. So it will save many neurosurgeons from medical legal cases. I agree.
Thank you. Thank you.
Thank you very much, Doctor.
Well,
Now we'll move on to our next speaker. We have Professor Abida Shah. Professor Abida is one of the biggest supporters of the Yemen Neurosurgical Society scientific programs, and she already gave many webinars and many presentations, and we all enjoy her presentations. Today, Professor Abeda will talk about the anatomy of the hippocampal formation. Dr. Abeda?
Thank you, Ahmad. Thank you for this invitation. And I have extended the topic a little bit to include the hippocampus, little bit of the limbic system, and some approaches for mesial temporal lobe surgery, because the hippocampus is too small a topic, or it is sometimes too vast, but it is too much detail to talk about the hippocampus. But this is the structure that we are going to discuss today. And you can see the beautiful hippocampus. It is called hippocampus because hippocampus means seahorse. So when you look at it in an upturned fashion, the hippocampus resembles a seahorse. So this is the face of the seahorse. So that is why it is called hippocampus. And it is divided into this head, body, and tail. And the tail continues as the fornix, and it becomes the columns of the fornix. And then it goes on to end in the mammillary body. So this is the structure. Now the hippocampus actually consists of the hippocampal formation, which consists of this proper hippocampus or Ammon's horn. It consists of the dentate gyrus, which I will show you, and the subiculum. So these three structures comprise of the hippocampal formation. And the hippocampal formation is laid down in the hippocampal fissure. Now let us see what all these structures are. So both the hippocampi of both the sides, they come together here, where the crura of the fornix meet here, And then there is a commissure here in the midline, that is the hippocampal commissure or the saltarium. It lies just beneath the body and the splenium of the corpus callosum. It is sometimes very close to the undersurface of the corpus callosum, and you cannot dissect it separately sometimes, but this is the region where the hippocampal commissure is there, and it transmits information between both the fornices. Now, if you see the location of the hippocampus, it lies in the floor of the temporal horn. Here you can see that this is the temporal horn, and the hippocampus will lie here in the floor of the hippocampal, of the temporal horn. So this structure here on the medial aspect is the parahippocampus. So the parahippocampus, now just be with me here. Parahippocampal gyrus, it turns laterally and it forms a ledge. Now this ledge is the subiculum. The subiculum in Latin, it means support. Now over this subiculum, the hippocampal formation rises and it is in the hippocampal fissure. So this whole structure here, so the parahippocampus will turn into the subiculum, which again turns to form the hippocampal formation, and again more medial to that will be the dentate gyrus. So we'll see these structures one by one. This is just to give you an overview. So if you look from a lateral aspect, this is the lateral ventricle, and you see the hippocampus, it is lying in the floor of the temporal horn, and here this is the choroid plexus in the choroid fissure. And the choroid fissure is a fissure that runs between the thalamus and the hippocampus and the fornix. So this C-shaped structure here is the choroid fissure, which runs here from the inferior choroidal point all the way back to the foramen of Monro. So where the anterior choroidal artery enters into the temporal horn, that is the inferior choroidal point, and the choroid plexus will run all the way here from in the choroid fissure and go to end in the interventricular foramen of Monro. So these are some important boundaries. So this is the choroid fissure. The hippocampal fissure lies just beneath the choroid fissure, and it lies between the parahippocampal gyrus, the subiculum, and the dentate gyrus. So that is where the hippocampal formation comes into picture. Now this is again a cut image that shows this gray matter of the hippocampus. And here you see it is closely related to this structure. I believe this is the topic of your next webinar, but I'll just show you this. This is the amygdala. So where the hippocampus lies in the floor of the temporal horn, the amygdala lies in the roof of the temporal horn. And you see that the hippocampus has a very distinct margin here to distinguish. The amygdala merges superiorly with the basal ganglia, more accurately with the globus pallidus. So this margin of your resection is important. You cannot do the dissection for epilepsy surgery here. You will enter into the globus pallidus. It has to be in this line. So you just take the amygdala and then take the part in the temporal horn and the mesial temporal structures. So this is again another image showing you the hippocampus. Here the temporal horn has been removed. This structure here is the amygdala, and the amygdala goes on to merge with the basal ganglia. So this is the basic anatomy of the hippocampus. Now let's go to the embryology. So earlier, when, in lower mammals, in lower animals, there was a spinal cord, there was a brainstem, and there was some corpus striatum on this. Later on, as evolution occurred, first the olfactory system developed. So this basically the olfactory system developed to get a sense of smell. That was the main sense of the organism, and that would alert the organism to danger. That's why these lower animals have very long olfactory nerves, because the sense of smell is their main sense, just like vision and hearing is the important senses for us. For them, the sense of smell is the most important one. For us, what happened around the brainstem and on the head, the thalamus is the head of the brainstem, and on the lateral and medial aspects of this developed two structures. On the medial side developed the hippocampus, and on the lateral side developed the olfactory or the pyriform cortex. So this was the primitive cortex, which was also called allocortex with 3 layers. And these two structures are the limbic structures, the primitive limbic structures. So the archicortex was the amygdala and the hippocampus, which were medial to the thalamus. And the lateral part was the olfactory or the pyriform cortex or the paleocortex. Now, surrounding this 3-layered cortex, there developed a cortical ring that consisted of the parahippocampal gyrus, the cingulate gyrus, and the insula. This ring is the paralimbic structures and the insula, and it consists of 6 layers but it is mesocortex. And around this undeveloped the neocortex or the isocortex, where you have all the parainsular structures and the neocortex. So this is what I said. This is the brainstem. This is the thalamus, which is actually the head of the brainstem. And medial to this here developed the hippocampus and the amygdala, and lateral here developed the olfactory cortex. Now, as evolution occurred, this whole turning of the hemisphere occurred. So the structure that was here, the hippocampus that was here, got dragged all the way down into the temporal lobe, following this C-shaped formation. So from here, the hippocampus turned all the way down here to come to lie in the temporal horn. So it formed a whole C-shaped structure. So this is what happened to the hippocampus. So it came from here down and went all the way to the temporal horn. Now, in the superior part of this hippocampal formation, there were the corpus callosum developed. So the fibers of the corpus callosum actually invaded this hippocampal formation, and it became very small in this region. So this part of the hippocampus developed more, this part of the hippocampus developed less. So there are some remnants of the hippocampus which lie above the corpus callosum, and this we know as the inducium griseum and the medial and lateral longitudinal striae of Lancisi. So they actually come here, run from here, consist of the continuation of part of the hippocampus and the dentate gyrus, go here as the supracallosal remnant, as the inducium griseum, and come to end here in the paraterminal gyrus, in the subcallosal region. So this is a limbic circuit. Just like you have the Pape circuit, this is the supracallosal limbic circuit. And there are other limbic circuits which we will not discuss in detail, but I will just show you. The Pape circuit we are going to see today. This is the dorsal amygdalofugal pathway that consists of the striae terminalis. This is the ventral amygdalofugal pathway where it connects to the temporal stem to the olfactory region. Then, of course, the Pape circuit, and then the supracallosal circuit. So the limbic system, this whole core developed at the edge on the medial aspect of the hemisphere, and that's why it is called as limbic. Limbic means border or margin. And all this I will show you on the medial aspect. The whole system is the limbic system. So it was actually first referred to as the limbus, then Broca called it le grand lobe limbic. MacLean called the cortical, subcortical, and all the fiber connections the limbic system. And Notta extended the limbic system to include the midbrain. So basically, Pape postulated that the anatomical basis of emotion was found in the hypothalamus, in the anterior thalamic nuclei, in the cingulate gyrus, hippocampus, and its interconnections. And this is very true, as we will see today in the Pape circuit. For those who are interested in more information, can read this. So these are all the components of the limbic system. So the most important one is this hippocampal formation. Then you have the amygdala, the hypothalamus, the nucleus accumbens, the cingulate cortex, areas of prefrontal cortex, and nuclei of midbrain. And the fibers that are involved in this are the cingulum, the longitudinal striae going above the corpus callosum, the fornix, the anterior commissure, the mammillothalamic and mammilotegmental tract, the striae terminalis, the dorsal longitudinal fasciculus, and the medial forebrain bundle. So these are the whole components of the limbic system. We are just going to concentrate on this hippocampus for today. So I will show you this now in dissection, how the hippocampus looks when you come from medially, how it looks when you come from laterally, and how it looks when you come from inferiorly. So this is coming from medially. So this is the corpus callosum. We know this structure very well. As I told you, on the superior aspect of the corpus callosum, there is the thin remnant of the hippocampus, or the inducium griseum. It's a very thin layer of gray matter. And within it, you see this white structure that is running. That is the lateral and medial longitudinal striae of Lancisi. So this is the supracallosal circuit. Here you can see the striae more nicely. Here you can see the longitudinal striae that are running on the surface of the corpus callosum. Now coming to the limbic, to the medial aspect, the next important structure is the gyri that are involved in the limbic lobe. And the first one here is the cingulate gyrus. So this is the one that is lying above the corpus callosum. And there is another interesting thing. These sulci that you see here, this subcallosal sulcus, this cingulate sulcus, the subparietal sulcus, the anterior part of the calcarine sulcus, this whole thing is also known as the limbic fissure. So just beneath the limbic fissure, you have the cingulate gyrus, which continues down here as the parahippocampal gyrus. The parahippocampal gyrus is also connected to the lingual gyrus by this offshoot. So both these gyrus together continue as the parahippocampal gyrus. So on the medial aspect of the hemisphere, here I told you that this is the beginning of the choroid fissure. This is the interventricular foramen of Monro. This is the fornix, this is the thalamus, and this choroid fissure runs all the way between the fornix and the thalamus to form the choroid fissure. Now, when we dissect more medially, so this, when you come from medial, so the first thing that you see here is the parahippocampal gyrus. Beneath the parahippocampal gyrus, you trace these fibers and you will see this, there are fibers that end here. This is the radiation of the cingulum. So cingulum begins here in the subcallosal region, goes superiorly and comes to end here as the radiation of the cingulum. Some fibers also connect to the cortex as cortical connections of the cingulum. This is important to understand how emotion gets converted to higher cortical centers. So coming back here, this is the mammillary body. So the fornix ending here in the mammillary body, and it is continuing as the mammillothalamic tract to end in the anterior nucleus of thalamus. So I am simultaneously dissecting the medial aspect of the temporal lobe and also of the ventricle, the thalamus and hypothalamic region. So here you see this, if curve the specimen, you can see the anterior nucleus of thalamus. You see another tract that is going down here. That is the mammilotegmental tract, which goes all the way down to the midbrain. Now here you can see within the ventricle, the septum has been removed and you can see the caudate head. So now you see how this radiation of the cingulum is coming here. Now this region here is the uncus, or the region of the amygdala in the hippocampus. So the anterior part of the uncus is the amygdala. The posterior part of the uncus is the hippocampus. We'll see this more better when you see from the inferior aspect of the brain. So then again here, this region here, that's this structure that you see here is the anterior commissure. This is the mammillary body. This is the mammillothalamic tract, and here this is the columns of fornix. Now here you can again see the anterior thalamic nucleus very nicely. Now here we have gone further. Now I've deflected this radiation of the cingulum down, and you see the whole structures of the hippocampal formation. So this is the proper hippocampus, or the Ammon's horn. Here you see this denticulate structure. This is the dentate gyrus. So this sulcus that separates this fimbria and the dentate gyrus is the fimbrio-dentate sulcus. The fimbria begins as a band of fibers on the surface of the hippocampus. They start as the alveus. Alveus means a band. And the alveus continues here as the fimbria, which goes up and continues as the fornix. So this is the beginning of the efferent pathway of the hippocampus. So the fornix is the main efferent pathway of the hippocampus, and this is how it begins here with the alveus and the fimbria. So this is the dentate gyrus. As I showed you, see, parts of the hippocampus and the dentate gyrus go here above the callosum, and this is the inducium, and continue here as the inducium griseum. Now going further, the dentate gyrus has been removed, and now you can see the whole hippocampal head. You can see the fimbria going on to become the fornix. And this region that you see here, this fissure between the thalamus and the fornix, is the choroidal fissure. Now going further, now I've cut the corpus callosum here, and you see this body of the caudate head lying in the floor of the lateral ventricle. So once I lift this caudate head, you see fibers that are running beneath the caudate head, and these are fibers of the anterior thalamic radiation. So here you can see this is the anterior thalamic peduncle, or the anterior thalamic radiation, and they go on to end here in the region of the cingulum. Now you can see that this whole structure is now the Pape circuit. So it begins here in the hippocampus, becomes the fimbria, the fornix, the body of the crura, body of the fornix, the columns of the fornix, the mammillary body, the mammillothalamic tract, the anterior nucleus of thalamus, the anterior thalamic radiations coming here to end in the cingulum, which turns back here in the radiation of the cingulum and ends here in this entorhinal cortex, or in the region of the hippocampus. And this whole completes the circuit, which we all know is the Pape circuit. And this is the Pape circuit that has been dissected outside after delineating it on the medial aspect of the hemisphere. So now we saw the hippocampus from a medial aspect. Now let's come inferior. Now inferiorly, this region is the parahippocampal gyrus. You see it turns anteriorly into this rounded structure, which we all know is the uncus. The uncus is very closely related to the cerebral peduncle. So there are two cisterns here, the crudal cistern and the ambient cistern. And there are some important vascular structures that run in this cistern, which we all know. So now again, you see this structure. This is the parahippocampal gyrus continuing here from the cingulate. It turns ahead anteriorly to form this region that is the uncus. This sulcus that is here, separating the parahippocampal gyrus from the collateral, from the fusiform gyrus, is the collateral sulcus. And the most anterior part of the collateral sulcus here. So this sulcus that you see here is the rhinal sulcus. And the rhinal sulcus is the second sulcus to appear phylogenetically. The first sulcus to appear is the hippocampal sulcus that is between the subiculum and the hippocampus. So you see this rhinal sulcus separates this cortex from the neocortex. So it separates this uncal region from the temporal pole. And this is this is the second sulcus to appear in the human brain. Now here you see how closely related the uncus is to the cerebral peduncle. And here you see the uncus with the relation of the posterior cerebral artery here in the crural cistern, how closely they are related, and we all know the significance of this uncal herniation. Now, another important thing of this uncal region is this anterior part. So it can be divided into an anterior segment and a posterior segment. So the anterior segment of the uncus is the amygdala, and the posterior segment of the uncus is the head of the hippocampus. Now let's see that in images. So now this is the inferior aspect here. You see the cerebral peduncle. So I've removed the gray matter of the parahippocampus. So the first structure that you see is some fibers that are ending here, and that is the radiation of the cingulum. This is the region of the uncus where you can see that some gray matter has been removed. These are fibers that are just at the ependyma of the temporal horn, where the radiation of the cingulum is ending to come in contact with the entorhinal cortex. Now, once I lift this, I see the ependyma of the temporal horn. Now, you can also see simultaneously I'm removing gray matter of the uncus also here. Now, when I lift this ependyma, what do I see? So now imagine that there was the uncus here. As I told you, this is the anterior segment and this is the posterior segment. So the anterior segment directly leads to the amygdala. The posterior segment leads to the head of the hippocampus. So this is the region of the uncus, and this is how it looks from an inferior aspect. So this is the hippocampus, the head, and the body. Now in this region, you can appreciate this pes hippocampi. You see, the paw-like structure that we called. This is called the pes hippocampi. This is the choroid plexus in the choroid fissure, and these fibers are actually fibers of the Mayer's loop, as we will see now. So now when I deflect this hippocampus, remove it downwards, you see this structure here. This is the region of the lateral geniculate body in this region. So the part of the thalamus, from here fibers arise. You see these fibers that arise and they curve laterally to go in the roof of the temporal horn in the anterior aspect and in the lateral wall of the temporal horn in the posterior aspect. And this fiber bundle is the Mayer's loop. So you can see the optic tract coming here and ending in the lateral geniculate body. Now you can see this Mayer's loop more nicely in this image, originating here from the lateral geniculate body and going laterally. Now this Mayer's loop actually turns here, and on the lateral aspect of the hemisphere, you can see this more nicely as it continues as the optic radiations. Now, there are many approaches that have been described to reach the hippocampus. So this is important for us neurosurgeons. So we have described an approach to the temporal horn where it is safe. I will show you this approach. This is through the middle temporal gyrus. Yasser Gill described this trans-Sylvian approach to reach this region, but this is a little dangerous because the uncinate fasciculus comes in the way and may be at risk to injury. Then there is a supracerebellar approach that has been described to mesial temporal regions and an inferior temporal gyrus, so approach to the hippocampus. So a lot of these approaches have been described. The main important thing of these approaches is to avoid injury to the fiber bundles that come. So we saw the hippocampus from medially, we saw it from inferiorly. Now let's look what happens laterally. This is what is most important to us as surgeons, because this is the view, this is where we operate. So now the hippocampus lies when you start your incision in the middle temporal gyrus. So when you enter into the middle temporal gyrus, you will enter into the temporal horn, and then you will see this is how the hippocampus lies. So this is the head, the body, and the tail. This is the roof of the temporal horn. This is the floor of the temporal horn. And what are the fibers that will come? So on the lateral aspect, you will have the arcuate fasciculus, you'll have the middle longitudinal fasciculus, and more inferiorly is the inferior longitudinal fasciculus. Now, these are just some things that you should remember. This will not come in the way when you're going into the hippocampus, unless you are really going in some other trajectory. The IFOF will come in the way, which I will show you. So this is the arcuate fasciculus, this is the SLF, this is the IFOF, this is the uncinate fasciculus. And down here is the inferior longitudinal fasciculus. This might be in the way when you're operating in this region because it comes in the region of the inferior temporal gyrus. So this is the IFOF as it is running here. And this whole bundle here is the sagittal stratum, which is consisting of the IFOF, the anterior commissure fibers, the optic radiations, and the tapetum. And this whole block is important. This is not the topic for today. Now, this is the approach that we have described. So now you look at this IFOF. In the anterior aspect of the temporal horn, this IFOF is in the roof. And in the posterior aspect of the temporal horn, the IFOF is in the lateral wall. Both, this is the combination of the IFOF and the optic radiations. So in this anterior aspect, this is the head of the hippocampus in the temporal horn. So in this anterior aspect, there are no fiber bundles. So this is a very safe region to enter for epilepsy surgery, for approaching mesial temporal structures, for parahippocampal lesions. You can safely enter from here and then carry on your resection without having any damage to the Mayer's loop and to the IFOF. So here you can see in another diagrammatic representation, this is the roof. You can see this area where I put the pinhead is safe of any fibers. It is only laterally that these fibers are come. So when you enter here and you remain beneath the roof of the temporal horn, you're relatively safe and will avoid injury. So we described this approach. Professor Goel described this approach for epilepsy surgery. We started using this middle temporal gyrus and we started entering from this anterior aspect and then removed this whole region. So we enter the middle temporal gyrus, reach the temporal horn, disconnect the amygdala here in the roof, remain beneath the roof, and disconnect this whole structure in an en bloc fashion. And this was our amygdalo-hippocampectomy combined with a temporal neocortex resection. And you can read this paper on our subject. So now coming back here to the choroid fissure. So this again, we are seeing the hippocampus. I keep coming back to the choroid fissure because this is an avenue here. When you enter the choroid fissure from here, you will go into the ambient cistern. When you enter here in the region of the atrium, you have avenue straight to the quadrigeminal cistern. And here in the lateral ventricle, when you enter, you have avenue to the, and you can enter into the third ventricle. So it is a very important fissure. You can see the star that I made, and that is the choroid fissure between the hippocampus and between the thalamus. Now a view from the top is the same choroid fissure that is running. This is the central core of the brain, which is bordered laterally by the insula, and medially it reaches the ventricle. So the central core is insulated between the ventricles on one side and the insula on the other side, so that it is safe inside. So these are the various limbic connections, which we will not discuss today, but you can see that I showed you a supracallosal circuit, then there is the Pape circuit, then there is a dorsal amygdalofugal pathway, and then there is one on the ventral surface, that is the ventral amygdalofugal pathway. And this actually model depicts all these limbic structures in detail. Now just coming lastly to the approaches. So when you understand this anatomy, you realize that there are beautiful avenues to reach the brain. So to reach this cistern, suprasellar and the ambient cistern, we described for the first time a lateral supracerebellar approach. So this middle fossa, this epidermoid tumor is entirely in the middle fossa. And we went from posterior fossa up and removed this tumor and this epidermoid in the cistern and in the medial temporal region. Then you see this tumor is a huge glioma in the region of the parahippocampal gyrus. You can see the tractographic images. All the fiber tracts are displayed superiorly. So it is safe to enter from this region, enter into the temporal horn and enter into the tumor in the region of the parahippocampal gyrus. And here you see the tumor and you see the radical resection. We have used this middle temporal gyrus approach to reach this. This is again another low-grade glioma exactly in the region of the parahippocampal gyrus. So here you see this is the region of the uncus. Here you have the hippocampus and here you have the parahippocampal gyrus. Again, you can come from this trajectory. It is safe. You can come from the inferior temporal gyrus. The only fiber bundle here, which you see here, I have mentioned, is the ILF, the inferior longitudinal fasciculus. This red thing is the tumor. You enter from here. The tract is above. You can go in and perform a beautiful radical resection without causing any harm to the patient. Now, this is a proper mesial temporal tumor involving the hippocampus, the amygdala, and the parahippocampal gyrus. So you can see the trajectory, a middle temporal gyrus approach, enter into the temporal horn, go medially, and remove all the structures. Now, this is a beautiful low-grade tumor here. So you see, this is the amygdala. and a part mainly in the amygdala, this tumor. So this is the location of the tumor. Again, you can see the trajectory. It is entering from a middle temporal gyrus approach. You enter into the temporal horn, you identify the roof of the temporal horn and the floor of the temporal horn and remove the tumor. Now, this tumor is involving both the amygdala, the hippocampus, and the region of the parahippocampal gyrus. You can see this structure. You can imagine with this anatomy, this image here, and exactly you can make out where the tumor is. You enter from the middle temporal gyrus using this cortical incision. And of course, here we've gone radically and done a good radical resection of the tumor along with the adjoining cortex, and the patient has done well. So there are some other tumors. So this is a tumor in the choroid fissure. So I was telling you the anatomy of the choroid fissure. So the choroid fissure is between the thalamus and the fornix, and this is an epidermoid tumor that was actually coming into the choroid fissure. Again, this middle temporal gyrus approach, you enter into the temporal horn, enter into the choroid fissure, and you can remove the tumor without causing any problem. Again, another beautiful tumor in the parahippocampal gyrus extending into the region of the temporal horn. So the trajectory is very simple. You come here from the anterior aspect so that you do not damage the fibers in the posterior aspect of the temporal horn, and you enter into the tumor and you see the radical resection. So lastly, there are some connections between the limbic system, between the telencephalon, diencephalon, mesencephalon. So this is the striatum medullaris. It is this structure. It runs from the septal nuclei here and goes all the way to the superior leaf of the pineal gland here, which is the habenular commissure. So this structure here is the striatum medullaris thalami. The fasciculus retroflexus is from the habenular nuclei to the midbrain, so going all the way from the habenular commissure down. And this is the medial forebrain bundle from the septal and lateral preoptic region going to the midbrain tegmental. So that is the limbic system and some parts of the hippocampus that I've just shown you today. And I hope you have enjoyed my lecture. Thank you very much.
Thank you very much, Professor. Dr. Khalid, please your comment.
Thank you. Thank you. Very interesting lecture. Thank you for all. Thank you, Dr. Ahmad. Thank you for all for speakers, and thanks for all colleagues. No any comment.
Thank you, Professor Abida. It's a very nice lecture and very enjoyable as always. We always you have shown us very nice dissections and very nice pictures. So thank you for this very nice and thorough presentation. I will see if there is any question from the chat. Also, that everything was very clear, but let's see if anyone have any question or any comment. Okay. Let's see here any questions. Okay. Dr. Abida, I have one question, please.
Yes.
You show in some of the cases that you show, you do resection of the part of the temporal lobe for the amygdala and the hippocampus. In case of this region in the dominant hemisphere, what is the safe boundaries that you do during operation to not to affect the language and the critical areas?
So there are two things. You have to preserve the cortex. So the cortical area that is eloquent is in the posterior part of the superior temporal gyrus. So on the dominant side, on either side, you're not going into the superior temporal gyrus. I'm always in the middle temporal gyrus and below. I'm not causing the superior temporal sulcus at all, ever. So my cortical area is safe. The second landmark is I'm entering into the anterior aspect of the temporal horn, and then I remain beneath the roof. I never violate the roof of the temporal horn. So that keeps the IFOF safe. So that is how you preserve language. You remain beneath the roof of the temporal horn and you remain beneath the superior temporal sulcus. Then you will not have a problem.
Thank you very much. Okay. Dr. Khalid, do you have any comments or any question for Professor Abida Shah?
No, but I enjoy with the answer of Dr. Shah. Frontal for center of speech. It is really temporal is opposite for frontal. Frontal is middle gyrus. Frontal gyrus is dangerous. Superior is better. temporal, middle is better, and superior is dangerous. This is opposite for idea for Dr. Shah for speech. Thanks.
Thank
Thanks.
you. So thank you very much, Professor Obeida. And next week, you will talk about the Olympic system. Yes, Professor?
Next week? Next week, no. I will tell you the date next time. Okay. Next week
Okay.
I'm out somewhere, so difficult. Maybe after that.
Okay.
Maybe
Okay,
we'll
we'll
change
see.
the topic little bit. If just send me the list of topics, we'll see how to change it a little bit so it will be more
Okay,
information.
we'll discuss
Okay.
and see.
Yeah, we'll
And
discuss.
regarding the timing, it will be next week will be in Ramadan. So what timing you prefer? To be in the evening, we delay 1 hour, or to be in the afternoon at 3 p.m. Yemen time, or 5:30 p.m. India time? What do you prefer?
Let us fix the date. Depending on the date, we'll set the time. Okay.
Okay. So thank you very much.
Okay.
So I think by this we can conclude our 7th session of the comprehensive neuroanatomy educational course. And so we see you all next week, inshallah, with more speakers and more presentations. And thank you, Dr. Khalid, for moderating this session.
Thank you.
And
Thank you.
congratulations again for your promotion to Professor of Neurosurgery
Thank you,
at
Dr.
Hadramaut University.
Thank you, Dr.
Thank you, everyone, and see you all next week, inshallah. Thank you.